अभी स्क्रीन स्टार्ट होने वाला है, उसमें कर दो। यस 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 मैम। हाँ गुड आफ्टरनून।
Yes. So we'll start with the explanation. So we have very comprehensive advanced and multifaceted laboratory with experienced staff, advanced in interactive technology. So we are one of the fastest lab that receive LNG accreditation. So we have CAP, PTs, antibiotic and sufficient survey as well. And we have 1,200 plus partnerships with hospitals and clinics with 20 scientists with a combined experience of more than 100 years. We are engaged into proprietary research and development, and we have a very world-class body information system. So we're talking about infection today. So infectious disease, which are the disorders that are caused by organisms such as bacteria, viruses, parasites, and are the leading cause of death worldwide. 3 infectious diseases were ranked in the top 10 causes of death worldwide in 2020 by the World Health Organization. There are lower respiratory infection, diarrheal diseases, and tuberculosis. To deal with the challenges in diagnostic infections, which is quite hard to diagnose infection, changing the changing nature of infection. Sometimes patients have multiple infections and with antibiotic toxicity and antimicrobial resistance is there. And what are the other the things that we challenge that we face with lack of signs and symptoms of the inflammation? Lab findings like PCT, potentially not reliable. Sometimes culture sensitivity is very low, around 20%, and it takes around 24 to 72 hours for any actionable report. Pathogenous organisms and fungi are not detected early enough. Low sensitivity in antibiotic treated patients. Virus not detected in a routine microbiological lab, and no time to readily assess response to antibiotics. Broad spectrum antibiotics are usually the most viable option, but the cost of healthcare for patients with resistant infection is higher than the phenotype. So, quite last two data of last 2 decades we published there, and we found that it was given that Indian antibiotic consumption is more than double in last 2 decades, which is in the latest report is been increased by 116%. So early diagnosis can help in reducing the antibiotic burden. So as per the CDC guidelines, as per the CDC survey, there up to the half of the antibiotic usage in the human and most of the antibiotic used in the animal is unnecessary and inappropriate. So diagnosis of critical infection and microbiology, we talk about microbiology versus RT-PCR. There is no doubt that culture method is gold standard for identifying the causative pathogens in any critical infection. But unfortunately, blood cultures cannot give a full information. And this is less than 20% cases that we get some any culture positive results. So reasons may be prior exposure to multiple antibiotics and viruses which are not picked up by the routine lab culture, and AFD and fungi are very slow growing and need many days or weeks to see the growth there. So clinicians are forced to start and continue with the empirical antimicrobial therapy in the 80% of the cases. So major gaps in the diagnosis and management of the critical infections are which is culture is not suitable for critical infection when patient is exposed to pure antibiotic therapy, and cascade of the multiple tests one after another need time and money, and inappropriate antibiotic treatment may lead to decrease the chance of survival and increases the risk of multi-drug resistant superbugs. So how we can bridge up the gap? So the only answer is the real-time PCR syndromic panel, which suggests that we can do multiple tests with a single sample to identify a set of organism. And we are offering very low TAT, which is around 1 day. And the test is very highly sensitive and highly specific, and very less chance of false positivity compared to the conventional PCR. We identify the signature genes of each organism, and that's very useful in patients with pure antimicrobial therapy. Infection is the slow-growing bugs and viruses as well. So our RT-PCR panels that answer the dilemma in the management of the critical infections. So we have very innovative technology which is simultaneously detects multiple pathogens. Either it's a bacterial, viral, fungal, or any parasite in a single test. And it eliminates the need of the multiple tests there. So we have designed the test panel as per the American Infectious Disease Society of America. So which suggests that recommends that non-culture based, it should be non-culture based molecular diagnosis, and we detect accordingly the pathogen directly from the patient sample. So and it should target the specifically pathogen only. So we don't target we target the viral specific gene, and we don't target both the commensals. So no multiplexing. So nowadays very common that people are doing multiplexing with a single test, and it reduces the specificity and sensitivity. So we are not taking any multiplexing of the thing. So highly specific, highly sensitive other things, and it should be the test should be rapid, which is we are taking only 8 hours of process time, and which allows the clinicians to change the therapy within 24 hours. So we also detect in many times we detect polymicrobial infection as well, and that's allow us clinician to reduce the antibiotic uses, and if the patient has some viral or fungal infection, then antibiotics is of no use. So high quality. So we are abide by this NABL guidelines. So we were taking all kind of quality control quality control criteria. And what are the benefits of identity panels? That will surely give a definitive and accurate diagnosis, and which will drive the therapeutic decision within a day of the patient admission, which will help in ruling in or ruling out the infection, or definitive and rapid detection of the fatal fungal infection, improve survival rate in the critical infection, and helps to establish antibiotic stewardship, switching to targeted escalation of antibiotic, antiviral, antifungal within 24 hours. And it will give patients an increased survival outcome, reduce risk of Ambia superbugs, and in transplant cases, helps in resolving the dilemma between the inflammation induced by rejection with the infection. Right. So we are abide by this and all quality control criteria, and following the CAP and annual accreditation standard. So we target around 120 pathogens. We cover around 120 pathogens, and which is among bacterial pathogens are 49, fungal 12 pathogens, parasites 5, and 57 viral pathogens. Our antibiotic resistance panel has 32 markers, which is covering 5 classes of antibiotics, and our assays are developed in-house. We have the ability to customize the investigation and choice of pathogen as per the clinician request. So I'm just giving the highlights of the syndromic evaluation that we do. Generally, we get the sample for statistical panel, the antibiotic resistance panel, comprehensive respiratory panel, atypical pneumonia, community acquired pneumonia, neutropenia, post-transplant panel, comprehensive CNS panel, cardiac panels like infective endocarditis and myocarditis panel, comprehensive viral identification panel, ophthalmic, osteomyelitis, and fever and acidity like that. In sepsis and ABI markers, that why we get tested. So sepsis patient in ICU of tertiary care hospitals are already treated with antibiotics. So current gold standard automatic blood culture is positive only 20%. That too after 72 hours. So 80% of the patients are treated without a microbiological diagnosis, and which delays the target therapy and it leads to prolonged stay in the ICU. And it always increases the cost of treatment and mortality and morbidity. So what we cover in the statistical panel, we have, if you see that brochures given to you, if it is available to you, then you can provide. Not available, you can have it. And we detect 9 gram positive bacteria, 21 gram negative bacteria, and 2 fungi. So 14 antibiotic resistance marker, extended spectrum beta lactamase, vancomycin, methicillin are included in that. We also look for pan bacterial and pan fungal genes for added certainty. So our detection rate is around 45 to 40 to 50% of the cases. So clinically, we can apply this panel for all septic cases who have pneumonia, soft tissue, skin infection, urinary tract infection, abdominal infection, etc. Suspected infection in patients undergoing hemodialysis or peritoneal dialysis, and helps the doctor to shift from empirical to evidence-based targeted therapy within 24 hours, help to de-escalate antibiotics and antifungals, and repeat the test. We recommend to repeat the test before discontinuation of antifungal therapy. Any kind of the samples we can accept. So neutropenia post-transplant panel is for the patients who are suffering from hematological malignancy on chemotherapy, and patients before or immediately after bone marrow transplant, post solid organ transplant patients on immunosuppression are extremely susceptible to infection by fungi and bacteria. So most of these infections are resistant to antimicrobials. Current gold standard, which is microbiology, catching up 20% of the cases, and in most of the cases, the PCT and fungal infections are PCT is not helpful, and fungal infections are remains undiagnosed. So we help with that with the 35 pathogen testing within a single sample. So we target around all 35 pathogens in gram-negative, gram-positive bacteria, fungi, and virus as well. So sample type, any kind of sample type that you can send to us. For sometimes doctor needs only viral pathogens to be checked on. So we have a separate panel for that in post-transplant cases where the patients on immunosuppression, latent viral reactivation leads to infection, which can cause organ damage and subsequently lead to graft rejection. These latent viral infections are therefore potentially fatal, and transplant viral panel can detect 9 viruses there. And the clinical application of this panel is definitely diagnosis of reactivation of latent viruses, evidence-based use of antivirals, and which allows the titration of immunosuppression process as well. Generally, we accept samples for this panel, plasma and serum. So respiratory panels that include community acquired pneumonia, that panel as well. So when, why and when you can use this panel. So children with respiratory infection which are treated with antibiotics at optimal level, and which leads to increasing resistance against common antibiotic. So our if IG's this respiratory and community for pneumonia panel is well suited for patients who are suffering from respiratory infection contracted from the community as well as other respiratory infection. So we target 38 pathogens, which includes 21 virus, respiratory virus, 3 fungi, 13 gram positive and gram negative bacteria, 1 atypical bacteria. So clinical application is definitely diagnosis with the positive agents in severe pneumonia. Distinguish between treatable and non-treatable viruses causing single clinical infection manifestation, and identification of the atypical pneumonia. In CNS infection, which is a very life-threatening infection, which while wrong treatment in CNS infection is life-threatening and delayed treatment is brain-threatening. So we provide the rapid, accurate, and comprehensive diagnosis for which can prevent mortality and morbidity arising out of the CNS infections. In the viral encephalitis, so diagnosis of viral encephalitis requires an algorithm of various tests, including microbiological, immunodiagnostics, individual PCR, viral cell culture, etc., for a comprehensive diagnosis. This is neither feasible nor practical in a clinical setting. Viral CNS panel is developed for patients presenting with classical signs and symptoms, along with cytological and radiological pictures of the encephalitis. Viral CNS panel comprises 8 DNA viruses and 12 RNA viruses. It helps in the patient, for the patient that for definitive and rapid diagnosis of both sporadic and epidemic encephalitis, and can distinguish between treatable and non-treatable viruses causing similar clinical manifestation. Early evidence-based initiation of antiviral will help once if we get some diagnosis with some kind of infection there. So CSF from lumbar puncture or brain biopsies are the recommendations. In a bacterial meningitis, so diagnosis of microbial ecology in meningitis patient presenting with signs and symptoms of meningitis, acute bacterial meningitis like with a fresh case with neutrophilic predominance in the CSF, or partially treated by bacterial meningitis where the lymphocytic predominance in the CSF, or chronic meningitis. And it helps identification of the causative pathogen involved in infection of the bacteria or fungi, and distinguish MTV. So it has panel has 15 bacteria, 3 fungi, AFB, MTV, and more in the panel. And clinically, we can apply for patients having clear-cut meningeal sign or when meningitis is the predominant clinical picture. And partially treated bacterial meningitis, typical of tertiary care setting, and allows to categorically rule out the presence of bacteria or fungus before the start of immunosuppression. And it helps diagnosis of infection post neurosurgery. Extended comprehensive CNS panels, where there is a problem, the doctor is not able to decide that whether the infection is bacterial, fungal, or viral. In that case, we help the clinician, and we test almost 46 pathogen in this panel, where it's all including MTP and what DNA virus, RNA virus, to parasites, and gram positive, gram negative bacteria are included in this panel. So, clinical application is for definitive diagnosis of the positive pathogen in case of clinical meningeal encephalitis syndrome, where neither CSF cytology nor radiology provides conclusive indication of the type of pathogen, and is best suited for a tertiary care setting where a classical meningeal or encephalitic picture is a rarity. Most suited for immunocompromised or immunosuppressed patient where neither imaging nor CSF cytology shows any evidence of the inflammation. You can customize the panel as well, because we have ability to customize the panel. You have ability to customize the panel because we are running individual tests and These are in-house. So in case of cardiac panel, so we have one panel which is infective and comprehensive endocarditis panel, and it's endocarditis is an endovascular infection associated with the persistent presence of infecting microorganisms in the blood. For this reason, blood culture and PCR are the standard test to determine the microbiological ecology of the infective endocarditis. Standard blood culture incubation requires 5 days to report. So molecular diagnosis provide a better alternative. Molecular methods are increasingly utilized to aid in the diagnosis of the culture negative endocarditis and have been applied to both blood and excised wall tissue. Due to the relative abundance of the bacterial DNA in the wall tissue versus blood, testing of cardiac wall tissues with organism specific PCRS is more sensitive than the testing blood or serum. So this panel looks for 8 gram positive, 19 gram negative, and 2 fungi. Basically, we can apply for diagnosis of identification of the microbial ecology of the infective endocarditis, definitive diagnosis of infective infection of bacterial or fungal origin. So, the preferable sample is tissue wall tissue or EDTA blood. In myocarditis panel, where there are a lot of cases, the exact cause of myocarditis is not found. When the cause of myocarditis is found, it's usually an infection that has made its way to heart muscle, such as viral infection, which is most common, or a bacterial or parasitic infection. The dangerous thing is about myocarditis that it can affect anyone, occur at any age, or it may proceed without displaying any symptoms. So this panel, we look for 17 viruses, 5 gram positive, 8 gram negative, and 3 typical bacteria, 3 fungi, and AFD, and 1 parasite. So clinically, we can apply for the patients who have myocarditis, and which are hard to diagnose because you can resemble many other diseases like drug or chemical poisoning or lupus or rheumatoid arthritis or any other infection. So molecular testing provided definitive diagnosis in suspected infection. Blood or tissue are recommended. We have a different panel, very unique panel, osteomyelitis panel, which is it helps in the diagnosis of the infection in the bone. This can then occur, which can occur when bacteria or fungi invade the bone. In children, bone infection most commonly occur in the long bones of the arm and legs. In adults, they usually appear in the hip, spine, and feet. So bone infections can happen suddenly or develop over a long period of time, can lead to loss of limb or life. Synovial fluid culture positivity is very poor if we see the result of the microbial, compare the result of the microbiology and molecular test. So microbial ecology is needed to arrive at appropriate time. Joint infections, which are essentially are polymicrobial, and will help this test help with detecting the polymicrobial diagnosis. And generally, gram-negative resistant bugs are on the rise, as we've seen in the lab results are. And very important to distinguish between MTB and non-tubercular mycobacterium. So we look for, in this panel, we look for 8 gram positive, 18 gram negative, MTB and NPM and 3 other fungi. Will definitely help in microbial diagnosis of microbial ecology in bone infection. Definitely diagnosis of infected infection caused or replacement. Samples which is acceptable are synovial fluid and bone tissue. In ophthalmic panels, we have a number of large, quite high number of panels. So very unique, and but I'm just highlighting 1 or 2 are there. So why I want to use this test? Value culture of vitreous fluid and aqueous humor specimen in the diagnosis of the infections and the calamitis is well established. But negative cultures are encountered resulting in a clinical dilemma or the cause of inflammation. Specimen amount of the both aqueous and vitreous fluid are very small, so discussion must be exercised in determining for which agent the specimen should be examined. So this panel looks for 7 viruses. 6 gram positive, 13 gram negative, 2 epithelial bacteria from the fungi and parasite. And molecular testing provides a definitive diagnosis of suspected infection. Samples that we can see, we can accept for aspirate from the anterior chamber or vitreous chambers. So generally, samples are sent in the syringe, and the syringe should be placed in the leak-proof outer container of the glass. In post-surgical endophthalmitis panels, we cover 5 gram positive, 5 gram negative, and fungi. And similarly, the same sample type can be used. In uveitis retinitis panel as well. So we cover in that panel toxoplasma, cytomegalovirus, viruses, cytomegalovirus, HSV, Gelsler, and tuberculosis. Pyrexia and arboviral fever panels. So we don't know sometimes the exact cause of the fever. It's lasting for last 7 days, 3 to 4 days minimum. So whenever a patient suffers from a fever for a long duration and underlying cause of fever cannot be determined, so this test can be used for that for those patients, or for those patients having one or more of these symptoms like fever, symptoms of fever with chills and rigor, fatigue, headache, abdominal pain, constipation, weight loss, or or to detect the virus or parasites causing the fever. So this panel can be used for that. So we target around 8 pathogens in this sample. So dengue, chikungunya, salmonella, West Nile virus, Plasmodium, Infectious, Zika, and Leptospira. So generally, we are seeing sample all that. Similarly, STD panel, one should wait for why and when this test. One should wait for a minimum of 4 weeks from the time of exposure before taking the test. Sexually transmitted infection can take a period of time to become detectable, and you must wait to ensure an accurate result. So what we are testing in this panel, so we have 9 pathogens like Neisseria gonorrhea, Chlamydia, Trichomonas, Myrioplasma aeruginosa, Myrioplasma pyogenes, Mycoplasma just 1, 2, and Gardnerella. Generally, we are using sample urine, oral serum, and I will skip these MTB and LPM. This is already explained. So we have a little bit of data that we are going to show you. In CNS infection, we have a 51% detection rate, and which out of these 38% are accounted for virus, and 42% bacteria, 11% fungi, 9% AFP, and other things. In febrile neutropenia post-transplant cases, we have detection rate 59%, and virus account for 34% out of these positive, and bacterial fungal pathogens are 34 and 38% respectively. And in 4% of the patients we got antigen. In comprehensive respiratory panels, the positivity rate is 84%. And viruses account around 39% of the infection. Bacteria and fungal account for 53 and 8%. This is the last year data. So we have other panels which have around already we discussed about endophthalmitis panel, which has a positive rate of 54%. Meningeal or CNS panels have 47%. Pyrexia is 45%, myocarditis panel has 43%, and septicemia around 40%. So there are some data which we have already published out there. Time parameters, we can give you very interesting case studies as well. I will just go with that one with that. Well, the Shankara Hospital, Bangalore, which was in that sample that pneumocystis jirovecii was diagnosed in the blood. So there was a patient, a 73-year-old female patient, and she was suffering from diffuse large B-cell lymphoma and receiving chemotherapy. Came in with fever since 4-5 days, weakness and decreased oral intake. Doctors suspected sepsis and started the patient on higher antibiotics. How the patient responded poorly to that treatment. So doctor requested us to run the septic panel and customize it while excluding leptospira and including PCP in that. So he was strongly suspecting an infection with the litter. So we ran a required investigation directly on the patient's blood sample and reported the sample positive for PCP within 24 hours. So based on that report, the patient was started to appropriate treatment immediately and showed remarkable improvement in 2 days and was shifted from the ICU. And another case where in the hospital. What was the presentation of the patient? Yes, it was. Patient was having diffuse large B-cell lymphoma. Fever or something else? Yeah, she was having fever. Nothing else. But no, otherwise, other weakness and oral intake was also not there. That was doctor's suggestion, so that we have to follow that. Sorry. Why you picked up 2 infections by your molecular? Next slide. Next. So it was the No. Leptospira. He don't want to test leptospira. He wants only PCP. So he told us to just remove leptospira and that and then include PCP because it is not included in the substance. So he just advised us. He just instructed us to change the pathogen and give us report on PCP. He was. I don't know. This is quite rare case, but it was. Yeah. I'm not able to understand. Did not understand what you were saying exactly. What did you pick up exactly? We pick up PCP. PCP only. Yes. How did this lepto came? Lepto was there in the panel, but yeah, he wants to remove it. He was not suspecting lepto. He was suspecting PCP, so he replaced that pathway. So similarly, an interesting case study recently in the hospital in Mumbai. Actually, they have biofire with them, but still they have sent the sample to us. So actually, it's quite in detail. So I won't go in that thing. So there was one 16-year-old female with no comorbidity, no childhood illness, complete childhood vaccination, no history of COVID. However, she had a family history of contact of tuberculosis. Her father had pulmonary TB 2 years back. So she was admitted to the local hospital in mid-April last year, and after suffering from a little sore throat, cough, and low-grade fever 2 weeks. So she had received a course of antibiotic from a local doctor and was doing fine with the no investigation. She remained fine for next 10-15 days and attended her exams in the school 2 days prior to admission in the same hospital. So a day before admission to the local hospital, her condition deteriorated very badly. She was hypoxic, hypotensive, and was taken to local hospital in Ulhasnagar for 1 day. But she was not making saturation, so she was transferred to the Indian hospital in Mumbai for intensive care management. She got admitted there and was intubated and put on oxygen support. She was given with prone ventilation and oxygenation linked to the FiO2 of 100%. So differential diagnosis suggested bacterial infection only. So empirically, patient was given antibiotics, levocanon, azithromycin along with steroids. So lower respiratory samples they were not doing, and they interestingly they didn't send directly sample to us through hospitals. So they sent the patient's father to us, and they said that just take that sample and process the sample and give us that. So we have that with our respiratory sample, respiratory test panel, and we got Salmonella species detected low. It could be that we target on the DNA. So as the meropenem is suggested treatment for Salmonella, so that's why it was giving us a very low concentration in that sample. So the same sample was also tested for tuberculosis and gene expert, which was found positive for TB also. So along with other anti-tubercular treatment was also started, and patient condition improved and was discharged from hospital within 3 weeks. So these are the two. We have a lot of case studies with us, but I will just end up with this thing, and we just execute summary. We will just give you that we offer a unique panel which are very comprehensive, and no one is doing in India, worldwide, I must say. So that is in that comprehensiveness. So very short period of reporting time, that of 1 day, and very cheap as compared to the other companies by far, including other. So we are very, very economical. And fourth thing is we can customize the plan. Thank you.
The detect the rate of NTM in chronic surgical site wound infection.
You see, it remains around 6 to 10%.
Because it's very difficult to diagnose the NTM.
Yes, but
To
we are
diagnose the
getting,
species is very hard rate.
yes, we have NTM speciation as well on PCR. So within a day you can get those results as well. If you got, if you're suspecting NTM there, so we can make you to give you identification of that.
Like example is better biopsy, tissue biopsy or secretion.
Whatever you are, we can process all kind of samples, including formalin fixed paraffin embedded tissue. Even if you give in the normal saline, or if you want endometrium itself, or other sample, any kind of samples can be accepted. That is.
You say that we are moving towards virulence specificity.
Yes.
So have you incorporated all those organisms which are actually virulent organisms?
Yes.
So
We have
can
a
we
list of genes that the same thing we have given to the NMBL as well. So we have a list of genes which we target only for particular pathogen. So it's not generic one. So it's for specific species specific genes that we are targeting. And that makes us
sometimes
very
it happens that we send a sample and we get some organism which does not fit into the clinical picture. Suppose I get a bacteria or not.
yes.
But the CSF picture is not suggesting. Suppose it is suggesting viral meningitis.
Yes.
So can we conclude that all our panels are actually pathogen specifics, or can we conclude in that manner?
Yes,
There is no common cell in our panel. Can we say that?
Yes, we can guarantee.
And suppose I need to customize, तो वो सर तो लैब को स्पायरा तो हटा था,
Yes.
वो इसलिए हटा कि भाई इसको लाना तो पैसा उतना ही रहेगा. What was the reason? That was the reason.
Yeah, that was the reason. He was expecting that was that's why he
Included.
Your testing primers are designed for where?
So we are designing primer by ourselves.
Where is it happening?
It's happening in the lab.
In your lab.
In lab.
You're designing primer there.
We are designing primer and props.
You have R&D area there.
Yes, we have R&D. It's a number of scientists that around more than 20 scientists that we are in. So in process that we take help from each other. So someone from bioinformatics part, someone from biotechnological part, someone from clinical part. So that's all we work together.
And those things are being validated and published before you.
Yes, some of them are published, some of them we are yet to publish. Thank you.
Am I audible now? So good afternoon, everyone. I'm Dr. Soumya. I have just joined PET-CT department here. It's been almost a month now. I joined on 16th of December. So I thought I'd just use this platform to introduce myself also. I'm able to, get familiarized with everybody here. So I did my graduation and post-graduation from New Delhi. Did my further went on to do my DMB from Jasbeer Mumbai, Then I was with PGI Chandigarh for 5 years. Then I've been in Dehradun with the medical college for another 4 years. And then I was here at Jaipur, Mahatma Gandhi Medical College for the past 2 years. And now since 1 month, I've been here. So I did my graduation, completed everything in 2000 and 2010. And so here I am. And I hope to have a good interactive, clinical session here, not just as a CME, but every day in the department. That's what I hope to do, because PET-CT, unless I know what the clinicians want from me and whether what I'm giving it to them is of actually any benefit to them, we cannot grow as a field. So I'll just try to summarize few of the common indications here, just try to introduce PET-CT basic concept in a very crisp way. So the menu for the presentation, not for the lunch, is basic concept of PET-CT, FDG, which is the commonly used molecule, but not the only used molecule. The patient preparation and precautions, which both as clinicians and us as doctors, we need, as nuclear medicine physicians, we take care of. The procedure of the whole scan, the oncological indications, the non-oncological indications, non-FDG tracers, and the radioisotopes other than FAT. So basically, PET-CT is a combined gantry where we take PET images and the CT images, and the software fuses the images. So that's how we get both the functional and the anatomical data. So this is, so this image is the first image which we get. That is what we call the maximum intensity projection image. Here, this is the 3D image of the patient. I can use this. So here we get this maximum intensity projection image, which is a 2D, actually a 3D image, which appears in 2D planes basically. So we get a CT image, we get a PET image, and we choose the images. That's how we get both the anatomical and the functional data. And we use IV contrast as per the clinical history of the patient. So FDG is basically a structural analog of 2D oxyglucose, and it behaves the way glucose does. So every cell which has increased transporters expression, they have preferential more uptake of FDG. So mostly all the metabolically active cells, they will have more GLUT expression, and hence they will have a preferential uptake of FDG over and above the other usual or normal areas of uptake. So that is why we say that PET-CT is non-specific in the way that wherever there is increased metabolic activity, whether it is infection or it is malignancy, we will get increased uptake. So based upon the clinical, suspicion, the clinical signs and symptoms of the patient, that's how we interpret the study. So we get our FDG, soon we will have a cyclotron in the city. So FDG is produced basically in a cyclotron. We get it from Delhi right now. And the half-life is 110 minutes. That's the reason why in the afternoon we cannot have the patients in the because even if we have the activity, it will place. So this is the normal distribution of FDG, salivary glands, myocardium to some extent, liver, as baseline increased, intestines, kidneys, bladders, and brain, of course. That's why we say that we cannot, we are not, specific, or we do not claim to identify brain lesions. Only based upon the CT images, we take support of the CT images, and then we are able to comment upon the brain lesions. Otherwise, the bladder, again, since we have our FDG activity in the bladder, so we take delayed images to see if there is any mass lesion in the bladder which is taking up FDG. So this is just to sensitize everybody that this is the normal uptake, and that is why sometimes we do, we give Lasix to the patients, and or we have the patient delayed in the department for some more time to become more specific because of this usual normal physiological uptake which MDT has. So basic precautions, which these are not contraindications, they're just precautions which we need to take when which in certain patients. For example, pregnancy is not an absolute contraindication, but yes, FDG should be done only in pregnancy only if the benefit is expected to be more than the risk. Again, lactating patients can undergo FDG, provided the only instruction we give is that the lactation should be stopped for 4 to 5 hours after the injection. Then other things like claustrophobia, movement disorders, if we know that the patient has these, it's better we are told so that we are prepared to handle such patients. Then of course, patients with IV contrast allergies, we cannot inject contrast. We can still do a PET-CT study without the contrast. CKD patients, again, high creatinine, we will give Omnipac up to say 1.5 creatinine level. We give Vizipac up to 2 creatinine level. Beyond that, we do non-contrast studies. Then again, patients who recently undergone RT, chemotherapy, recent surgeries, we have to infer our study with a little bit of caution because any inflammation will also show increased uptake. That is why we need to take certain surgical, certain history details, which we do talk to our referral clinicians whenever we need. So post chemotherapy, if the time window allows, we prefer a gap of 3 to 4 weeks. Post RT, we prefer a gap of 3 months, but obviously depending upon how soon we want the PET-CT, the interpretations can be worked around it. So patient preparation, we need the patient fasting, but we do not need the patient NPO. So this is a usual, discrepancy that we ask for fasting and the patient is NPO, which actually, because of which the hydration status is compromised, which we do not want. So we want a well-hydrated patient, but fasting and, for 6 hours, approximately. Then well-rested patient, blood glucose levels definitely play a role because we are using structural analog of glucose. So we want that the tissues otherwise should, not be saturated with glucose. So in diabetic patients, if the glucose levels are more than 200, we do not do the study that same way. If the glucose levels are more than 250, then we ask for the stabilization of blood glucose levels for at least 3 to 4 days. And then we call the patient. For non-diabetics, we prefer fasting blood glucose to be 150 and below. So basic procedure, we give an intravenous injection of 8 to 10 millicuries of FDG. We have a 45 to 60 minutes waiting of the patient in which the FDG localizes. We give oral contrast in this time, and then during the acquisition, as per the clinical requirement, we give the IV contrast. Now, I'll just briefly enumerate the oncological indications. So for diagnosis, we do not play a very vast role, only in patients with PO, patients with whether suspected paraneoplastic syndrome, or evaluation of pulmonary nodule in certain specific scenarios. We do a PET-CT. So these are all images from the department. Most of the images are from the department. So here we had a patient of PO sent to us on the PET-CT. We found this pleural-based mass lesion, which we again suggested for pathological correlation because it looked like a malignant lesion. So this is another patient which came to us with this mass lesion. Why is this happening like that? Which way? We have any support? Okay, so we had this patient with a known mass lesion suspected to be CA lung for further characterization and for seeing if there are other lesions as well. So we found this one pleural-based mass lesion, which we suggested again pathological correlation for the same two again malignant. So another patient who was sent to us with suspected multiple myeloma because he had multiple lytic lesions But we, during the PET-CT, we saw there was this FDG event lesion in the base of the tongue. So finally, this patient was a case of CA base of the tongue with multiple skeletal and soft tissue and nodal metastasis. Another patient sent to us here itself with some pulmonary nodules, suspected CA lung again, but we found FDG event lesion in the relation to the superior pole of the left kidney. So suspected RCC. This is another patient sent to us with multiple lesions, infiltrative lesions involving almost entirely both the lobes of the liver. During the and there was some pulmonary FDG with pulmonary nodule. During the study, we saw there was this FDG with bowel wall thickening in the sigmoid colon. So this was suspected primary CA colon with hepatic and pulmonary metastasis. This is, its role in diagnosis. For staging and restaging, there are FDG PET-CT plays a vast role. Non-small cell lung cancers, lymphomas, esophageal cancer, gastric cancer, colorectal cancer, pancreatic cancer, ovarian, head and neck malignancies, breast CA, melanoma, CA prostate. So here are again few cases from our department itself. This was a patient of CA breast sent to us for staging, and we can see multiple cannibal lesions, metastatic pulmonary nodules, multiple hepatic lesions, which were again metastatic. So another patient, CA right lung, and on the PET-CT, we detected these multiple hepatic and skeletal metastases. Then this was another patient referred to us. This patient had undergone left lumpectomy, and in the lumpectomy was detected to have really need some support here, please. Okay, so patient was sent to us to see if there's any other there, because this was suspected benign lesion in the left breast. On lumpectomy, it was on histopathology proven to be IDC, and patient was sent to us to see whether there are any other lesions anywhere. So in the brain, in the left occipital lobe, we detected a lesion which on MRI correlated to be and appeared like meningitis. So, and this was detected on PET-CT for the staging purpose, but this did not look like metastatic based upon the characteristic of the lesion. Then again, we have a vast role to play in response evaluation. There are these criteria, PERSIST and iPERSIST. That is PET response criteria in solid tumors and iPERSIST PET response criteria in post-immunotherapy. So PET response criteria are based upon size, SUV max, which is a quantitative evaluation of the region. TLG and MTV are the TLG and MTV are newer quantitative values which are in the study apart from SUV max to comment upon the response of the lesion post therapy. So response evaluation largely it's helpful in lymphomas, in non-small cell lung cancers, pancreatic CAs, and especially pancreatic CAs. Early response is what is under the study right now. Breast CAs, esophageal cancers, pelvic malignancies, and multiple myeloma. Now, these are few of the cases from my department. This is again pre-therapy, and as we can see that later when the patient had come to us, developed a new lesion here, which was this mediastinal node. Again, this was this liver lesion which increased in size and in the metabolic activity, so giving suspicion of disease progression. Another example of disease progression, again, we had another patient with this left lung lesion here, which these pulmonary nodules developed later. So, and similarly for the liver lesions, they developed later. So again, giving us suspicion for disease progression. Then we have another case here, left lung CA, which is complete remission post therapy, both metabolically as well as size wise. We have another patient, again a mediastinal mass, which shows complete remission post therapy. Similarly for the liver lesions, these are FDG-able lesions before chemotherapy, and this was after therapy. Again, this was a patient who was a known case of CLL detected in 2016 or 17, had been fine all this while, came with some fever and chest breathing difficulty, and on the PET CT we saw these large nodal masses, mediastinal nodal masses, as well as retroperitoneal and abdominal pelvic nodal masses. So this was probably a conversion of CLL into aggressive lymphoma. So we asked for the pathological correlation from the nodes. Then again, we have a huge role to play in RT planning because FDG PET CT would actually margin out the area which is metabolically active, so which helps for RT planning. So that extra tissue is not irradiated. These are some pictures from the some journals and some studies. This is CA. This was a mass here in the right submandibular region, which was the FDG ability was used for RT planning. It was another right lung island mass lesion, and ability which was just localized to this part was made used for deciding the area to be irradiated. Again, this was a CA prostate where importance was given to this node, right iliac node. So these and again we have these nodes which were detected again in an evaluation for a CA prostate patient, and which helped in deciding the area for RT planning. Now, non-oncological indications. So PET CT is not, it has not just found a role in oncology, but it has huge list of indications in non-oncological fields as well. So prosthesis evaluation, vascular graft evaluation, vasculitis, sarcoidosis, TB, HIV, osteomyelitis, and Charcot's joint. So prosthesis evaluation, which is known to have a role for detecting chronic infection as well as acute infection, because it is found to have a role which is better as compared to many other modalities. Then we have this sarcoidosis and tuberculosis, not just for the pattern of which we use to detect whether it may be tuberculosis or sarcoidosis, but also to follow up post treatment. Similarly, in HIV, there's this Castaner syndrome, which is common. So, to whether it converts into active malignancy or it remains benign. If it does remain benign, then it responds to treatment again. So, to follow up in HIV patients. Then, chronic osteomyelitis, it has a very important role because no other modality can accurately detect chronic osteomyelitis in early stages. Charcot's joint, again, whether there is bone involvement or not, or is it only soft tissue involvement? And there are a few other places where it plays where these are established roles, but it is there are studies going on in inflammatory bowel diseases, rheumatoid arthritis, autoimmune pancreatitis, and fungal infection, where they're trying to see the role of PET CT. Cardiovascular diseases, again, PET CT has a huge role for viability assessment, for cardiac amyloidosis, endocarditis, myocarditis, pericarditis, DVT to ascertain the age of the thrombus. FDG-able thrombus is supposed to be, acute, whereas non-FDG-able thrombus may be a chronically lying thrombus. Atherosclerosis, again, vulnerable versus stable plaque. FDG-able plaque is supposed to be a vulnerable plaque, whereas a non-FDG-able plaque is supposed to be a stable plaque. Others, PO, neurology, we have epileptic diseases where FDG plays a role in interictal SPECT. Ictal SPECT, it is brain SPECT imaging, but interictal SPECT, FDG does play a role. Again, dementias by seeing the pattern of FDG uptake, we can comment upon which area is active, and we can follow a patient's post-treatment with dementia. Then again, endocrinological diseases like hyperparathyroidism. So to detect or if parathyroid adenoma is being suspected, then FDG PET-CT has a role which is actually more sensitive than usual SPECT parathyroid imaging. Because studies have shown based upon the vascularity of the adenoma and based upon the metabolic activity of the adenoma, FDG can localize an adenoma more sensitively than the parathyroid SPECT imaging. Again, thymic pathologies to differentiate benign versus malignant based upon the SUV max. And if we are talking about a malignant lesion, then it is more likely to have metastatic lesions as. So any thymic mass lesion can be evaluated on FDG PET-CT study, and we can give a fair idea about whether it is benign or malignant. Again, diabetes, various pathologies related to the diabetes can be evaluated post-treatment as well on PET-CT. So these are some images again from some journals and studies. This is an image of a patient with tracheobronchitis, and this was acute. And then again, PET-CT was used for follow-up post-treatment to ascertain whether it subsided. Then this is again FDG ability around the processes, and here we have vasculitis. This is the way we see FDG uptake. This is involving the aorta. This is the celiac artery. This is the superior mesenteric artery. So normally we do not see FDG ability in these vessels, but this kind of focal ability gives us a suspicion or gives us a diagnosis of vasculitis. So as of now, vasculitis cannot be diagnosed or can be followed up for any other investigation, but PET-CT is known to play a huge role in that. So this is another patient that we have. This is SPC involved inflammation. Again, this was a patient with PO, which was incidentally found to have a gluteus abscess on PET-CT. Now, these are other PET tracers or the newer tracers which are being used. So FDG was just the beginning of PET imaging. We have fluoride, we have PSMA, we have choline, DOPA, DOTA, and acetate, which we are doing, and they have their own specific indications. So PSMA study we are doing here. We are doing 18F labeled PSMA study. These images are from our department itself. So PSMA is basically prostate specific membrane antigen. So this study is specific to CA prostate, used for staging as well as follow-up to detect recurrence. So this is definitely more sensitive than FDG PET-CT and more specific for CA prostate patient. So this is a CA prostate patient with skeletal and nodal metastasis, apart from the local site lesion. This is another patient from our department itself, CA prostate, with multiple bilateral pulmonary nodal as well as skeletal metastasis. And we can see an infiltrative lesion here in the prostate, which is also going ahead to involve the base of the bladder. These are the rest of the newer tracers, which a few of them are under study and few of them are being used. So once we have cyclotron in the study, we may be able to utilize this better. So this is just the just about the PET-CT, very brief look to everything about PET-CT, and I hope to have more interaction with everybody. And any specific questions are always welcome pertaining to any particular tracer. So, yes, sir. Sir, creatinine up till 1.5, we are using Omnipac. That is, we are using IV contrast. Usually the way we use it. Between 1.5 to 2, we are using Visipac. So Visipac is not as toxic as Omnipac. So it does not harm, it is known not to harm the patient up to 2. And if the patient, and even if the patient is 2.5 or 1.9, and the patient is not a known case of CKD, but incidentally detected to have these levels, then IV contrast studies especially with Visipac, up to 2 are not known to harm the patient in any way. So, any other queries related to the department or any other issue related to the department, please feel welcome to discuss. And also we are planning to just take the initiative. I know there's a virtual tumor board already happening, but we're just thinking of every second and fourth Friday, if the clinicians have the time to, we will just allot days and venue. So if we have cases, then instead of a virtual tumor board, we can just have an in-person tumor board, so that we also get to know that where and how we played a role, or there any discrepancies in any cases. So those cases can also be brought into the tumor board. So because PET-CT itself is, it's a learning, every case is a learning point for us. And unless we get a feedback whether we were on the right track or we were on a different track, we do not know what we are doing. So I would just request that any kind of interaction, any kind of inputs you want from us in any presentation where you want our inputs, please feel free to, just call me. I can come and discuss because there is no point in my just sitting in the room and doing the cases if I do not have feedbacks from our people.
How long you are archiving data?
Sir, now I can assure that every data is going to be with us. How long it's going to be with us for good? We are not going to destroy any data. We were huge till date also. We were supposed to have all the data archived in the PACS, but there was some connectivity issue between PACS and us initially before I joined, and because of which some patient data was not made available and was not available. Because of which I also suffered, patients also suffered, clinicians also suffered. But now what we're doing, we're keeping a backup of all the patient data. Before we delete, we're keeping a backup in the department itself. We gave a few CDs to the MRD because they asked for it. They lost those CDs. So a lot of things happened because of which, we lost few patients' data. So now we have assured that we will have one backup on the PACS. If the PACS doesn't work, we're going to store the data on the hard disk as well. So all the data will be available on us. So we will not delete any data till we have the data completely on the hard disk. So this will not be an issue from now onwards that much.
So why I'm asking in the oncology and the science.
Obviously,
Really last week, being a radiation oncologist, I may require not where how to hear about the compare.
I completely agree. And
It's a problem, it's not a problem, really the problem is used to the problem also. The most of the cases are third party reimbursement. Their films, color films, their CDs,
anymore.
System does have the only black and white.
So now it's not going to be an issue anymore because we're going to have all the soft data with us on the hard disk. So this will never be an issue because for me also, I do not just want to see the immediate scan. I want to see how the whole disease started.
The prognostic value of the bed is immense.
Absolutely.
Unless you have the previous data, you cannot.
I agree. So that is the assurance what I can give them. Ever since that, whatever cases we have on the system now, they will not be deleted till we have put them into the hard disk. We have already floated this instruction in the department, and we're not giving the extra CDs to MRD anymore. We're keeping it in the department, or we're giving it one CD to the patient. That's the other thing which we're doing. That whatever the patient did in panel, non-in-panel, cash, whatever it is, but they need to have one CD with them. These two things is something which we have started doing now. So now I would also like to introduce my team. It's Ashaji, Vaishali, and then we can all receive Kalan. So this is Ashaji, our manager. This is Vaishali, our RSO. Ajo, Madan, Jay. So this is our radiographer, Madan. That's our nursing staff, and that's our medical guidance. And we are Rajendraji. Where is Rajendraji? I don't know. So this is the small team which we wish to expand by expanding the department and getting more, interaction with everybody. So any questions, please? Yes, sir.
Can we differentiate between inflammatory and malignant even in lung on the basis of SUV max values?
No,
To
sir.
some extent.
Sir, SUV max is just a direct indication. It's just, it depends upon the metabolic activity of the lesion. Metabolic activity can be high in malignancy, it can be high in infection as well. So just based on SUV max, we cannot, but yes, pattern of the uptake, pattern of the other lesions, the per se CT characteristics of the lesion, all those definitely can help us give, opinion whether we are more towards malignant or we more towards benign or we more towards infective. Those are the things in few or most of the regions we are able to tell our clinicians. We don't put it on the paper because we cannot, but we tell our clinicians that it looks like TB or it looks like sarcoidosis. If there's only nodal involvement in the mediastinum, there's no other lesion anywhere. So we will feel that, probably it looks like sarcoidosis. We give that kind of hint and then we ask for pathological report.
Can we
guided by
So we can make for some extent.
To an extent that I can tell you verbally, I might not be on the report, but I'll tell you verbally. If and in those cases where we completely can't see the lesion, and based on experiments, we can't. Yes, sir.
We do the CT guided biopsy.
Sir.
We want to tell you the net guided biopsy.
So red-guided biopsies are happening in many places now. So they require some official training for 90 biopsies at a place like PGI. So I was there at PGI and I've seen red-guided biopsies. So if we need to do that, I just need to take an official training certificate so that there are no legal assets. And we can do that. We may need some help from the our interventionist in radiology for some time. And then we can because it is happening at Mathur, it is happening at PGI, it is happening in many places. So if all that we need to do, I need to go and do that training for some time. Sir, this is happening. This is something that we can do. Any other? Anything else? I think everything is hungry.
समय दी मैम लाइव बंद कर दीजिए समय बोलने के भी हो गया अपना